The high features and benefits. The spatial resolution has phenomenally increased, 1.6 millimeter. 4 to 10 minutes is the scan time. Compact and portable, 3D tomographic images, and doesn't much disturb the breast tissue. A very important tool from a breast cancer perspective. Though we have other modalities, mammography continues to be the screening technique. There are issues, many of us know, I won't dwell in that. But in the MAMI-PET or the PEM technique, the sensitivity is now reaching as high as 97 to 98%. And mostly because that the breast is brought very close to the detector.
Hepatobiliary, Mugas, lacrimal, lymphoscintigraphy, all this long list that I've put up there, none of these require SPECT-CT at all. These will cover most of your bread and butter and jam. So where do we need SPECT-CT? And this is just a slide I put together. From our own department, as I've said, if you count the non-cardiac studies, 90% of the studies do not require SPECT-CT. It is only in those 10% where SPECT-CT can really add to your information that I'm going to highlight. We are very lucky that in our department in PGI we have 3 SPECT-CT machines, most of the work being done with the traditional Hawkeye. So I'll start with the cardiology, where, as I said, attenuation correction is the major part of it. We are trying to correct for diaphragmatic attenuation in the inferior wall, breast attenuation in the anterior wall. Again, with the newer 64 slice CTs now being available with the SPECT machines, one could try for CT angiography along with the myocardial perfusion studies, or maybe even calcium scoring, which has just started coming in. Of course, the cost of the machine is correspondingly higher. Now here you have a case of inferior wall attenuation. As you can see, if you can see the arrows which I've placed, that is in the inferior wall here. Now this is the non-attenuation corrected and this is the attenuation corrected. Now if you can see what looks like a fixed perfusion defect here in the inferior wall, especially if you see the transaxial image, it shows that there is definitely perfusion there, so that it is a viable myocardium in that part of the
did their job excellent. So a round of applause for all of them. With this we come to the end of the first session.
Thank you so much. And on behalf of the organizing committee, we will request our chairperson to kindly honor our invited speakers. May I request Professor B.R. Mittal to kindly provide a token of memento to Dr. B.A. Krishna. Now, may I request Colonel P.G. Kumar to kindly present a token of memento to Dr. Anish Bhattacharya. Now, may I request Professor B.R. Mittal to kindly provide a token of memento to Sharmila Banerjee, ma'am. Now, on behalf of the organizing committee, we will also like to honor our chairperson. May I request Dr. P.K. Pradhan to kindly present a memento as well as a shawl to our chairpersons.
My thanks to all the 3 speakers for telling the anatomy in detail of the CT, and a few speakers added the PET also and MR also. These 2 modalities are very essential for the nuclear medicine physicians. We must know all the details of this one. Day by day we will do more fusion imaging, and knowledge of anatomy of CT and MR is must. With these words, my thanks to my friend Dr. Prabhu and all of you. Thank you very much.
With this, I like to thank our chairpersons and speakers. Now, on the behalf of the organizing committee, I request our chairperson to kindly honor our speakers. May I request Dr. S.K. Sharma to kindly honor Dr. I request Dr. E. Prabhu to kindly honor Dr. Shailesh Gaikwad. Now may I request Dr. S.K. Sharma to kindly honor our Last speaker, Dr. Sanjay Tulkar.